So, good evening, everyone. Welcome to the CME of South Delhi Pediatric Study Group. The topic for today is pediatric cardiac issues in COVID-19 disease. The moderator for the session is Dr. Smita. Ma'am is a pediatric cardiologist at Holy Family and Manipal Hospitals. I would request ma'am to kindly introduce the speaker.
So, I think thank you very much, Dr. Poonam, Dr. Sankalp, for inviting me here as a moderator of session. Dr. Vikas Kohli is such a famous person, and it's my pleasure that I'm going to introduce him. And he was my examiner also during my FNB. So he's a very wonderful person. He's MD, American Board Certified Pediatric Cardiologist. He's director at Delhi Child Heart Center and visiting Apollo Rainbow Hospital. Dr. Vikas Kohli is known for his outreach program. So he's associated with lot many charitable program, but besides, uh, he is the person who introduced in Delhi that he visited in many places. He picked up many patients. Otherwise, it was like a monocentric setup for the pediatric cardiology when Escorts was only center in private setup. So he started reaching to various to support various hospital, various nursing home, and that is how he picked up so many patients so early, and it was really boom for them. Though at that time he was initially started from Gangaram and subsequently probably shifted to Apollo Hospital, and he was not having a very good backup, surgical backup, but still he kept on working hard. So he has many feathers in his hat, and everybody knows about it. So, and he is very good speaker. We listened him a few months back, and I always look forward to listen him because he is a very hardworking speaker. He will pick up a lot of things. He will read a lot, and then only he will come up with the whole summary of whatever he has read. So I am looking forward to learn more and more in today's session. Welcome, Dr. Vikas Kohli. Kindly take over.
Thank you very much for the very generous introduction. And thanks to Dr. Poonam and Dr. Sankalp and Dr. Arun Wadhwa, always from the South Delhi group. Today's topic is obviously hot, as is the city right now, very, very hot. And we'll be talking about pediatric cardiac issues in COVID-19 disease. Um, the role of comorbidities, what do we know? And heart happens to be a comorbidity if there is a pre-existing disease. In adults, factors associated with increased mortality include male gender, elderly, presence of comorbidities as high blood pressure, diabetes, cardiovascular, and cerebrovascular disease. But in pediatrics, with underlying conditions including those previously treated surgically for congenital heart disease or untreated CHD happens to be one of them. So what does the literature have to say? Cardiac disease and COVID-19, where do they cross over? They cross over if there is a pre-existing heart disease and the patient gets COVID-19, or has COVID-19 without any cardiac issues previously and has heart involvement during the acute phase of COVID or slightly later on. And this is going to be our mainstay of discussion. Let us get the pre-existing disease out of the way. So there's been a wonderful study which looked at, this is a European study, predominantly Italian, which looked at congenital heart disease results from a nationwide survey. And what they found was they had a total of 76 patients with cardiac disease who got COVID-19, and they were mostly treated and some of them untreated or awaiting treatment. Few of them had RT-PCR. Remember, last year, RT-PCR was not that easily available when this study was conducted, but others had suspected COVID-19. Total patients were 76, and they found that the most common presentation in these patients was heart failure. So that was the most common presentation. Apart from that, they could come with palpitations or arrhythmia, chest pain, myocardial injury, pulmonary hypertension from a respiratory disease, bad lung disease, pericardial effusion, respiratory failure, stroke, etc. The clinical manifestations were acute respiratory distress syndrome, severe cardiac complications, severe pneumonia, and mild respiratory syndrome, which was the commonest. So we leave this pre existing congenital heart disease here itself and move on to those patients who have not had a heart disease before and get COVID 19. Now, what is our local experience with the first group? Including the current patients who are suffering from COVID, 30 patients I've come across who have had heart disease or have just been treated for it or had been treated long time back or have severe residual heart disease, including Eisenmenger syndrome. They, some of them on 3 antiarrhythmics also have got COVID. None has required admission for deterioration of cardiac status. To the best of my knowledge, and I haven't gone back and questioned them, none of them even required admission for respiratory illness. This is very encouraging information from our local community because this implies that if you have a patient with VSD closure whom you're following who's quite old and gets COVID, you can assure them that it is going to run the same kind of course as other patients. Now let's focus on cardiac involvement in COVID 19 disease. So, mild clinical forms of involvement may be there, which I will discuss its nature of. And this will happen usually in very mild disease, the majority of the patients that we see, or in moderate disease, it may be a residue. And what it is, I'll come to that. It is not very significant, but it's worth mentioning because it can aggravate the parents a lot. The second important one is myocardial disease in moderate to severe disease, respiratory illness, or presentation of COVID 19 disease, myocardial involvement, and we'll be talking a lot about this. And in severe forms of involvement or in critical disease, COVID 19 disease, there may be severe heart involvement. So, what is the mild clinical involvement that we refer to first? And that is tachycardia. So you have a patient who's checking pulse oximeter at home, completely otherwise asymptomatic. The fever has come down, the tachycardia has not come down. I've had patients who had a tachycardia of up to 155, which persisted out of proportion, may need treatment. It is sinus tachycardia. There is a diagnosis for it, which is inappropriate sinus node tachycardia. Ivabradine is the usual treatment for it, and it is benign. Now, this is in total contrast to adults. Adults, COVID 19 disease without necessarily a pre existing cardiac disease present with bradycardia. Their heart rate is 40, 45, 50, 55. It doesn't go up, whatever may happen. So, this is in contrast, and you may come across this. If it is persistent and high, one may need to treat. An ECG is well in place. Now, myocardial involvement, this can happen in moderate disease, patients who are unwell, very rarely in mild disease also, may be seen in large number of cases. There have been French and Swiss studies, studies from UK, USA, which we will be going through. But if it's not looked for, it'll be missed. And in a very nice article on COVID 19 and the young heart, what are we missing? The authors specifically talk about myocardial dysfunction not being picked up because there may not be a specific manifestation of it. So, what causes the myocardial dysfunction? First, a direct viral access to the myocardial cells and damage. Second is the ACE2 receptors, which we will talk about. Third is the cytokine storm, and all the immune mediators and coronary involvement finally, which obviously is a major section of what we are going to talk about today. So viral heart muscle involvement, that is direct invasion of the virus into the myocardium, is related to a direct myocardial injury. Now, this data actually comes from SARS in 2005 when viral RNA in cardiac muscle was found in 35% of the overall infected subjects. And COVID may enter myocardial cells simply by binding to the angiotensin converting enzyme receptors. We know this very well. There was a lot of controversy in the beginning whether patients on ACE inhibitors should be stopped or not, their medications should be stopped or not. And we'll discuss a little bit about that also, why it is a positive thing in children. Patients taking angiotensin converting enzyme inhibitors and receptor 2 blockers, ARB, which inhibit type 1 angiotensin converting enzyme receptors, while cause an overexpression of type 2, might put them at a higher risk of cardiac involvement in COVID 19 infection. This we know from adults. But there is some more information in children, which is why kids are not just small adults, as we've always known, that in a review, authors have suggested and elaborated upon the higher circulating levels of ACE2 receptors in children. So they are not just fixated on vascular system, renal, and on cardiac receptors, but they are circulating also. And they have asserted that this could offer protection by means of buffering effect. So more viruses binding to the circulating ACE2 receptors than myocardium. And severe infection in elderly, they postulated, could possibly be occurring due to immune senescence, that is aging, of these circulating ACE2 receptor cells. Now, this is just a passing information which will help us understand why children are by and large protected from major involvements. Now, second form of myocardial damage, which we said is immune mediated, is inflammation. Hyperinflammation may play a crucial role in myocardial injury, and increased levels of inflammatory markers of a variety of type of them would actually be acting on the heart, and these were higher in patients admitted to ICU units than in those suffering less severe forms of illness. And we'll be talking about these later also. Lastly, even certain antiviral drugs and medications damage the heart and may cause arrhythmias, as we already know from our experience with adults. So, why are children still at a lower risk than adults? A restrained cytokine storm as a result of not fully developed adaptive immune system, less functional ACE2 receptors have been suggested as the main mechanism for reduced susceptibility in children. And after this, the myocardial issues, we move on to the real issue, severe cardiac involvement. Now, severe COVID disease happens in 2 to 6% of all children who are infected with COVID. They can be critical children who may get cardiac involvement. Severe myocardial disease itself may be a severe cardiac involvement. There may also be valvular and pericardial disease. What I have not mentioned here is coronary, because that's the crux of our discussion henceforth. So, coronary involvement in these patients is at three levels. One is Kawasaki disease. Second is incomplete Kawasaki disease, as we know very well from our clinical experience in non-COVID incomplete Kawasaki disease. And the third is the Kawasaki disease shock syndrome. This also we will refer to. These are patients who present dramatically within hours, deteriorating with hypotension, requiring vasopressors, and if they don't get that, they may not survive. So, what has been happening between Kawasaki and COVID 19, and what is the correlation? Historically, let's look at it historically. History has happened in front of us. In Europe, Italy was the first country to be affected significantly by the outbreak of COVID 19, which began there in February 2020. And from the Bergamo province, the epicenter of the Italian outbreak, Verdoni et al. First reported exceedingly high incidence of Kawasaki starting in March of 2020. A monthly incidence that was 5 times greater than the same monthly incidence of the previous 5 years was reported. There was a clear starting point after the first case of COVID 19 was diagnosed in the Italian epicenter. So there was a temporal relationship. Now, the cytokine storm, possibly due to activation of macrophages, similar to secondary hemophagocytic lymphohistiocytosis syndrome triggered, the condition has been named or termed multi-system inflammatory syndrome in children, MISC, in the American continent, and the pediatric multi-system inflammatory syndrome, PMIS or PIMS. Both are present in literature in the European and UK subcontinent. So whenever we refer to MISC or PMIS or PIMS, it is the same condition. It is the multi-system inflammatory syndrome in children that we are talking about. It's exactly the same condition. The TS here refers to the temporal relationship with COVID. So it is characterized by hyperinflammatory syndrome, multi-organ dysfunction, delayed by a there appears to be a delayed post-infectious response with a lag of 4 to 6 weeks at least, and mostly following asymptomatic exposure to SARS-CoV-2. So this is the key that one has to look for. Every patient who's exposed pediatric has to be told that a month later, if they get any rash, symptoms of fever, they have to report to the pediatrician immediately. Now, the first reports came in mid-April 2020. Clusters of pediatric cases with severe systemic in hyperinflation and shock epidemiologically linked with COVID-19 were reported. Rifagen et al. First described a case series of 8 previously asymptomatic children presenting with hyperinflammatory shock, ventricular dysfunction, and multi-organ involvement. The subsequently, the Royal College of Pediatrics and Child Health, the Center for Disease Control and Prevention, and WHO came up with the multi-system MISC or PMIS or PIMS definition criteria. Now, this is the WHO criteria, this is the Royal College of Pediatrics criteria, and CDC criteria. They all are practically similar. I'm not going to go through this table. There is another talk on the same topic, non-cardiac. I think it is tomorrow or day after, where it'll be covered in greater detail. So, clinically, children with MISC commonly present with persistent fever, asthenia, diffuse erythematous, polymorphic rash, non-purulent conjunctivitis. Sounds like Kawasaki, right? Prominent gastrointestinal symptoms is not necessarily like Kawasaki. And if your patient has, during acute COVID syndrome, a gastroenteritis or gastrointestinal symptoms, there is likely to be, and literature shows that, a higher cardiac involvement. Mucosal changes, peripheral edema, along with rash conjunctivitis resemble the clinical characteristics of Kawasaki disease. This contrasts with the adult late presentation of odinophagia and respiratory symptoms, which are rarely seen in kids. So clinically, notably, a subset of patients presents with hypotension and shock from either acute myocardial involvement or systemic hyperinflammation, vasodilation, frequently requiring immediate ICU admission, circulatory and respiratory support, and resuscitation. This is the similar to toxic shock syndrome. This is the Kawasaki disease shock syndrome presentation. Now, what is the predisposition? There is practically nothing that predisposes to this, except I came across only one study where they said that patients who are overweight, children who are overweight, may be at a higher risk of cardiac involvement. Otherwise, we will come across lab parameters, but predisposition before getting COVID, there is practically none other. What is the proof of infection in these? A small number of MISC patients, not a large number, and we'll go through the statistics when we look at the data, have positive RT-PCR. Majority have either known family exposure or serological evidence of prior infection. And I think most of us who've dealt with MISC have come across this particular information, and this is our experience also. Time from infection to MISC symptoms varies from few days to months. Generally, a higher percentage had evidence of IgG antibodies, suggests that a post-infectious immune response may be responsible for this condition. Now, I'm not going to go through this table about the sequence, but basically, MISC happens with symptoms similar to Kawasaki, or with shock presentation, or with severe circulatory failure. Apart from routine labs, one may look at cardiac biomarkers like troponin, BNP, NT-proBNP. You may call a pediatric cardiac referral if available, and they would look at the elevation of troponin or BNP, NT-proBNP, features of Kawasaki, features of myocarditis or shock syndrome, and history of previous congenital heart disease or other cardiac involvements, and do an echocardiogram to confirm the findings. Now, why does MISC happen and what happens to the acute phase reactants? I came across this acute phase response, which is different in patients who get severe disease, including MISC, that their IL-6 and chemokines are much higher and have a much delayed response, including the interferon response, which is also delayed. Their viral load is higher as compared to those who have mild disease, which is the cause. But IL-6 is a differentiating feature. Now, let us look at three main studies with the largest volume. What are their findings in the arena of either PIMS or MISC, whatever we may call it? Let's look at the European data, which is a collaborated data, and they have the largest number, 58 children with PIMS, which is temporally associated with COVID, so they refer to it as PIMS TS. Now they have 58 patients, out of which 45 had proven markers of active or recent infection. Clinical symptoms will not be discussed here because they should be discussed in the Thursday talk, which is a more basic talk. In general talk, I should not say basic. Nothing is basic here. This is a more specific talk that's more general about MISC. Acute phase reactants were positive in 53 out of 58, which is an important number. 50% presented with shock with myocardial dysfunction. So this is very, very important. Heart dysfunction is extremely important, and we'll tell you what kinds of heart dysfunction happens. Biochemical evidence of myocardial damage, and 13 met the AHA criteria of Kawasaki disease, which we are well aware of. 4 out of 5 criteria have to be met, and 23 had features of Kawasaki disease or shock with fever and inflammation. Now, children with PIMS-TS, as the authors refer to in this article, who developed shock had numerically higher CRP, neutrophil count, lower albumin, lower lymphocyte count, elevated troponin, and NT-proBNP concentrations compared with those without shock. Lab findings amongst children who developed coronary artery dilatation or aneurysms were not meaningfully different from those without coronary artery aneurysms. So you can look at higher CRP, neutrophil count, lower albumin, lower lymphocytes, and elevated troponin, NT-proBNP concentrations to indicate cardiac involvement, but not predict coronary involvement necessarily. So how is this different? What is different here is, if you think the patient is a little more sick than the usual, then add to it troponin and NT-proBNP in the cardiac biomarkers in your workup of the patient. Now, these 58 patients, they divided into 3 clinical courses. First, 23 patients had persistent fever and elevated inflammatory markers, but no features of organ failure, mucocutaneous features suggestive of KD or toxic shock syndrome. 29 children in the second clinical course developed shock, and often associated with evidence of left ventricular dysfunction, 62% of them, and with elevated troponin and NT-proBNP. Again, the 2 cardiac biomarkers which were present in 50% of the patients. 66% of those 29 had NT-proBNP which were elevated. And third clinical course was 7 children fulfilled the American Heart Association diagnostic criteria of Kawasaki disease. Of these, 1 progressed to shock. A total of 13 children met the criteria of Kawasaki disease when coronary artery aneurysms were included, obviously, which need to be included. So they had total 13 patients with Kawasaki disease. Now, the cardiac markers, troponin concentration were elevated in 68% and NT-proBNP in 83% of those who had the involvement. And this included two children who required ECMO in their subgroup. 8 children had abnormally dilated coronary arteries, which was mild dilatation incidentally, only more than 2 standard deviations, including 7 with Z scores greater than 2.5. Giant coronary aneurysm was seen only in 2 patients. The milder forms, which are mentioned in point number 1, incidentally, are the ones which regress over time. Giant coronary aneurysms are the ones which don't regress. Coronary artery aneurysms developed in 8 children, one with fever and inflammation, 5 with shock, one with mucocutaneous. So coronary aneurysms can develop in any of the 3 groups. It is not necessary that they will develop only in the shock group or in the third group, which is with the mucocutaneous features of Kawasaki disease. They can also come in patients, which is number 1 group, that is children with persistent fever and elevated inflammatory markers. So this is an important statement here, which we will refer to again. Other authors of other continents have also found this. So who develops coronary involvement? First of all, the comparison of PMSTS who developed coronary artery disease or aneurysms with those who did not failed to identify any difference in clinical or lab markers. So we cannot, by lab markers, know which patient will develop coronary artery involvement. We have to do an echocardiogram, the protocol of which I'll go through in the end. Of particular concern was the finding that coronary artery aneurysms were found in a subset of all 3 groups, which is something I highlighted earlier also. So all those 3 subgroup patients of MISC need cardiac follow-up and evaluation. The lack of association between the levels of inflammation in these groups of markers of cardiac injury and development of coronary artery aneurysm suggests that coronary changes are not solely a consequence of severity of inflammation. So we are dealing with PIMS-TS, which is MISC also, if we cross the continent at the Atlantic Ocean. And we are dealing with Kawasaki disease as a subgroup. We are dealing with Kawasaki disease shock syndrome as a subgroup. This is what we have understood till now. Any one of the 3, this includes a group of prolonged fever. Any one of these 3 could actually end up with coronary aneurysms. Cases of PIMS-TS generally occurred in children older than those with KD and KD shock, with different lab features. When PIMS-TS cases with coronary artery aneurysms were compared with pre-COVID-19 KD cases that developed coronary aneurysms with PIMS-TS tended to be older, more intense inflammatory markers, higher levels of markers of cardiac injury, suggesting that these 2 are separate entities and that treatment of PIMS-TS may need to be different than that of Kawasaki disease, mainly in the form of vasopressors being required. So coronary artery dilatation or aneurysms have been described in 6 to 24% of patients in variety of studies. Most, luckily, are mild coronary artery dilatation with Z score of 2 to 2.5. Some of the findings, which means mild means they will regress hopefully. Some of the findings in the acute phase may be related to coronary vasodilatation in the setting of fever and inflammation. This is a very, very important statement. Why? Because we know as pediatric cardiologists that we see some degree of coronary dilatation, which is a vasodilatation in non-Kawasaki fever and inflammatory syndromes, apart from COVID-19 also. So in general fever inflammation, there can be a coronary vasodilatation, which is not a coronary aneurysm. Now, reports of large and giant aneurysms and progression of coronary aneurysm following discharge, raising concern of coronary artery disruption, intimal disruption. The late development of aneurysm highlights the need for ongoing follow-up of these patients. So this point, I would like to say, progression of coronary aneurysm following discharge raises a major concern. This is unlike Kawasaki disease. In my experience of so many, and I have lost count of Kawasaki patients I've seen, which is non-COVID, it was only one patient to date, and I have never forgotten her. Her name is Charu, an older patient who had come to me where there was a progression of aneurysm after discharge, after treatment and discharge. But in COVID-19 Kawasaki disease, I've already seen that happen in 1 out of the 2 patients with aneurysm that I've seen, which I'll highlight later. In the shock syndrome patients, 7% manifest hemodynamic instability, referred to as KDSS. Let's go on to the US data now. Now, this US data, if I'm not mistaken, is from Children's Hospital of Pennsylvania, and they had 28 patients with MISC. They reviewed the parameters, acute phase of MISC, KD group, and subacute, which is at interval of 5.2 plus minus 3 days. Only one case in their whole study manifested coronary artery dilatation with Z score of 3.15 in acute phase, showing resolution, early follow-up. Left ventricular systolic diastolic functions were worse in MISC, and the strongest parameter to predict myocardial injury were several high-end parameters, which are referred to as global longitudinal strain and circumferential strain, left atrial strain, and peak longitudinal strain. I don't mean to highlight, but these are just terms that are coming up in pediatric literature, which you will hear more about. So these are very, very early parameters to measure mild forms of ventricular involvement, and they usually suggest late ventricular dysfunction happening in these patients. So if 5 years later, we come to know that some almost asymptomatic COVID patients develop dilated cardiomyopathy, then we know that we are dealing with those who had a very mild form of cardiac involvement, which can only be measured by these rather than just by ejection fraction. The preserved LVEF group in MISC showed diastolic dysfunction. So it is not just systolic, it is also diastolic dysfunction. During subacute period, LVEF returned to normal. This is very encouraging that within a week, the ejection fraction returns to normal. Unlike classic Kawasaki disease, coronary arteries may be spared in early MISC. Myocardial injury is common, as we know from the European group, which has presented 58 cases. And even preserved ejection fraction showed subtle changes in myocardial formation, suggesting subclinical myocardial injury, which they did not study with troponin I or NT-proBNP. So we move on to the Boston study, which is also retrospective, where they looked only at the function of cardiac function in MISC, and they talk about the review, myocardial dysfunction, and they reported that the first one reporting was from UK, 75% patients out of 8 patients, 6 had this. And in subsequent case series, ventricular dysfunction has been reported in 35 to 100% children with MISC, depending on definition and inclusion. That is, if you include diastolic dysfunction also. Others have reported a selected cohort of 35 MISC patients who developed acute LV failure. We know that they manifest with acute deterioration or shock, fever, and elevated inflammatory markers. Other authors have reported 20 patients admitted with cardiogenic shock. 19 out of the 20 required inotropes vasopressors, but no ECMO support was needed. High proportion of patients also had elevated troponin I levels in other studies and NT-proBNP, as we know from the main study. So what are the echogenic echocardiographic manifestations? Coronary artery dilatation, as shown here. Mitral regurgitation is shown here. Pericardial effusion, as shown here. And myocardial systolic dysfunction, as shown here. This is another patient with coronary involvement, and you can see the ectasia, not an aneurysm, mentioned here. And so if there is MISC, and we look at the cardiac involvement, there could be coronary arteries which could get involved, or cardiac injury or dysfunction, injury referring to biomarkers, cardiac biomarkers being affected, and dysfunction referring to systolic or diastolic or left atrial strain or RV strain getting affected. Now, what is the protocol for follow-up? This is extremely important for everyone attending this talk. Echocardiogram repeat 5 to 7 days or prior to discharge, and repeat it 7 to 10 days if within normal limits. ECG every 48 hours. And I'm not going to go into the treatment part. That is not part of the agenda I plan to discuss. Exercise restriction for 2 weeks with no evidence of cardiac involvement. that is normal ventricular function, and normal troponin levels for 3 to 6 months if evidence of cardiac involvement. Now, this statement is not cursory. American Heart Association, American College of Cardiology, and American Academy of Pediatrics last week came out with this recommendation that patients with MISC are restricted from severe exercise for 3 to 6 months. And this is an important recommendation you would need to make to your patients. More frequent follow-up may be required for those with ventricular dysfunction and coronary artery dilatation. How frequent? So there is a follow-up at 7 to 10 days, 4 to 6 weeks, 4 to 6 months, and 9 to 12 months. So basically, at 1 week after discharge, an echo prior to discharge, 1 week after, 1.5 months after, 6 months, and 12 months. And one may require to do a Holter because arrhythmias, which I haven't gone into because of the vastness of that field also, one may need to look at arrhythmia. So ECG is good enough for now. If we see anything on ECG, then Holter. Now, what do we know from India? There is only one study reported from India, which is last year from Mumbai, 23 cases of MISC, 19 cases MISC echoed to. Now, these 23 patients, they had 4 patients with coronary involvement. What is my personal experience? 19 cases of MISC echoed, 2 patients with coronary involvement. One has already recovered, one has a large aneurysm. He had resistant Kawasaki disease in addition to MISC, and 4 with severe ventricular dysfunction that I have gone through. Now, why are we lacking in Indian data? Practically everyone attending this talk has seen one patient or heard of one patient. We need to collaborate. This is our time to do it. If you're willing to collaborate and share your data, obviously, last point is very important. Just email or contact on WhatsApp or just call me. And I think we need to get together and get some data together and make a publication out of it. Otherwise, all of this will go away. And we would have talked of something happening in our lifetime live in front of us for the first time and still no publication happening. Thank you very much, everyone, for your attention.
Thank you very much, Dr. Kohli. Really lucid presentation, very well done. And I would like to comment before listening to any other comment, my own experience. I have seen a single patient with aneurysm, coronary artery aneurysm, where the COVID antibody was positive. So, the mostly other patients, they presented with coronary artery ectasia rather than the aneurysm. And I have at least 3 patients under my follow-up as of now, COVID antibody positive. Then what my understanding of this disease is that definitely MISC is different from the regular COVID disease in adult. But it is like immunological response, which comes very early in the adults after 6-7 days. That is as if delayed for 3 weeks or 4 weeks. So you are getting almost all immunological thing happening over there, cardiac involvement, and it's like a Kawasaki disease shock syndrome. But it is, and the all interleukins and all those TNF alpha and all immunological stormy thing, but everything is happening quite in delayed fashion. And I think why we are not getting more of coronary artery, I would like to take your suggestion also, that why we are not looking more of a coronary artery aneurysm in MISC, because most of the time these patients are presenting with a sick disease. They are more sick, and we are compelled to give steroids and the IVIG early once we suspect that it can be a, because the presentation is more like a Kawasaki disease shock syndrome. So most of the time we give early IVIG as well as steroid. So probably this may be preventive, and it may protect the coronary artery aneurysm. But we cannot say that long run coronary artery functionally how they could be. There might be abnormality still, and of course there is a myocardial involvement and all features of myocarditis. I have seen many patients who actually went slowly into shock, cardiogenic shock. But the best part, what I have observed, that these children, they actually come out of it very nicely. The cardiac function is restored in within few days. That is what is my experience. Kindly tell yours also.
Yeah, this disease is frightening in some ways because of the severity of cardiac involvement, especially the shock syndrome can be such that within hours the patient reaches a point of devastation and complete circulatory failure. On the other hand, it is also disheartening to see that there are giant aneurysms happening and resistant Kawasaki disease happening. But I think the more important message is that coronary involvement can happen in any of the three subgroups. This is my take home message, that if you have MISC with prolonged fever, or if you have the shock syndrome, or if you have the classical Kawasaki presentation, all three subgroups will can have coronary involvement. And the only way we will know is if we look for the coronaries actively. That's how we will come to know. So echocardiogram is the way to do it. Not all patients are in the ICU, but those are in the ICU will definitely get an echocardiogram. What is also very disturbing is the increase in size of aneurysm after discharge. That is very disturbing. That has not been seen before. And in that one patient with giant aneurysm whom I'm following, this is exactly what happened also. So with this, I think there are some questions for Dr. Sankalp. And one is, any role of CPK-MB? Yes, there's always a role for CPK-MB, but troponin is more specific than CPK-MB. We would always need a CPK total with a CPK-MB. Is NT-proBNP easily available? Yes, it's available in all hospitals. Adult cardiologists use it all the time. It is actually used very frequently as an outpatient monitoring test to know the variation in cardiac disease by both pediatric and adult cardiologists. Cardiac involvement typically occurs after how many days of fever? So it can be acute also, but as you heard, MISC is typically a delayed response, but it has also happened acutely. Majority of the patients of MISC will be a delayed response, and majority of the patients will have IgG antibodies positive rather than having an RT-PCR positive. And on digging, there will always be a history of somewhere of an asymptomatic patient or a contact. Any data on cardiac involvement in of the new variant? No, I don't have any data. I think we all are in such a storm right now. Should all patients with acute symptoms be informed about late complications? I think acutely, we don't need to worry acutely unless the biomarkers are very high, unusually high. Those patients one should worry about. I think that is the subgroup in the acute. Usually, we should tell the acute patients one thing, that if you have any of these symptoms a month later, that is conjunctivitis, rash, or fever, which is restarting, please think that this is a complication of COVID. And please, I'm telling the patients to actually mark it on their calendar a month later and inform me that there is none of these symptoms present, because otherwise they will just present with shock in the emergency room and a 2-3 day history of fever, and we would feel bad about it. So I think that's something we can inform them. Should all patients with acute symptoms be informed about late? No, not late complications, as I mentioned. Since methylpred is used in MISC and IVIG, must, along with cases having coronary artery dilation. Dr. Rajiv, treatment of MISC, I have left for Dr. Emmeline. She's speaking tomorrow. I really wanted to not encroach at all in her area, and I noticed that she is also in the audience. I would like to, actually my talk should have been after hers, but due to logistics, etc., that couldn't happen, which was not in my hand necessarily, but she would be covering most of this. I don't want to, discuss this issue, but if you have heart involvement, you need to give, especially coronary involvement, you need to give IVIG. If you have heart involvement, again, you need to give IVIG.
Oh,
About the collection of data, I think this is a brilliant thing. I welcome anybody and everybody to please share the data. If you want to form a Google sheet and put your data there, anybody wants to take a lead, anybody wants to be the first or the senior last author, please do it, but let's just do it for a change.
Dr. Neeraj Awasthi is in audience. Dr.
Yes.
Neeraj? Dr. Neeraj Awasthi?
Hello, ma'am. Yeah, it was a wonderful talk. Sorry, I wanted to be taking all the knowledge, but I'm caught. Hello.
Dr. Kohli, you are on mute.
Yeah. Am I okay now?
I can hear Dr. Vikas, but ma'am, I couldn't hear you actually. You just heard my name and then I got lost. Sorry. Sorry, you're on mute, ma'am.
Dr. Savita, I think you can unmute everybody now.
Okay.
Yes, ma'am, I just did it.
Your experience, if you want to share something.
It was a wonderful presentation. I think it summarized very nicely. I fully agree that in acute phases, we are finding a lot of post-COVID involvement with cardiac involvement. Coronary involvement is definitely less observed than other cardiac involvements in the form of valvular regurgitations, pericardial effusions, which are much more common, and of course ventricular dysfunction, as Vikas sir has highlighted. So sir has nicely covered everything. So I think it's it.
There's a question about what percent of MISC patients develop cardiac involvement. So it depends on how you define cardiac involvement. If we include cardiac dysfunction, the statistics vary between 35 to 100% in the series you're looking at. So diastolic dysfunction is present in almost all the patients. Strain abnormalities is present in almost all the patients. Coronary involvement obviously has been much less, as we have seen that there are between 8 to 13 patients out of the 58, and the variation is up to 24% maximum reported coronary involvement in MISC patients. Those are the statistics. What percent of acute COVID will have MISC? I would say 2 to 6% of acute COVID may have MISC, but I stand to be corrected if there is more data on this. Dr. Emmeline is going to cover this, and she would be a more authoritative person to speak on this.
Dr. Poonam, you want to ask certain question?
No, I think he's already covered whatever I wanted to ask. So it's covered now.
Like Kawasaki disease, also sometimes aneurysm may keep on increasing. At least one patient I detected aneurysm at the age of 3 months, and up to around 9 months, this aneurysm went on increasing. And then subsequently it regressed and regressed completely. So it was very strange presentation for Kawasaki also.
There's an interesting question. A patient of Kawasaki disease gets COVID. What is the chance of coronary involvement? I think it's a hypothetical question. I don't have the answer to that. I'm sorry. Incidentally, cardiac disease patients getting COVID, I haven't seen an increased incidence of them getting admitted for cardiac reasons.
So
if I may just intervene about that question regarding a previous KD patient getting MISC. There was one patient which somebody in southern part of India did see around October, November last year, who had a previous history of KD and then presented with MISC. I'm not very sure what the follow-up results were, but now that we are talking about it, I would definitely try to touch base and find out what actually happened to that kid.
Thank you.
Yeah. Okay, thanks.
And I was talking to Dr. Hema from Ramanol Loya Hospital, and she was very clear this time MISC is more happening with the patient underlying heart disease. So Dr. Kohli said so, and this is really a well-observed thing in various pediatric setup. MISC is happening more and more in the patient having congenital heart disease.
There are a few other questions. Cardiac MRI in kids with MISC. So cardiac MRI has been studied in patients with MISC to better define coronary involvement and myocardial involvement. And obviously myocardial inflammation is very clearly seen on cardiac MRI. It has not been done in acute COVID disease because of obviously logistic issues of doing an MRI. Though that has also been studied in one particular study. They did cardiac MRI in acute COVID disease. Any age predisposition for cardiac involvement in post-COVID Kawasaki? Yes, they are older patients. Those who have coronary involvement are older patients compared to other Kawasaki patients. This is very striking. They also have more gastrointestinal symptoms. Acute phase reactants are more and biomarkers are more in these patients.
And a good observation made by Dr. Arun Wadhwa, since all patients are getting COVID, all KD patients are prone to get someday.
Yes, true.
That is true. Good
That's
observation.
very true.
Unmute yourself.
Are older patients also at risk of post-COVID KD? Yes, older patients also. Incidentally, Kawasaki also happens in older patients, and we have seen even in teenagers and post-teenage years, we have seen Kawasaki disease. Okay, Dr.
Dr. Wadhwa is saying that he posted few more questions actually.
Yeah, I'm going through them. Yes, have you noticed any difference in the new variant? Yeah, I can't say that yet, but obviously what we have noticed is it's happening a lot more in kids, and therefore all kinds of kids, and therefore kids who have had heart treatment and heart surgeries where parents were extremely careful previously, now it's affecting them left, right, and center. So I will be getting all the cardiac patients, that is pre-existing cardiac disease, who have COVID. I'll be getting them for follow-up echocardiograms and seeing what happens. So there are several spin-off changes, and I think there is a role of collaboration amongst pediatric cardiologists, pediatric intensivists, and pediatricians, which should be happening. Why only studies should come out of Boston, and how are we any lesser than the Bostons and the children's hospitals in US and West? Why should we not collaborate and share our data and come up with a publication, is my question to all of you.
I completely agree, sir. I think we have a robust data, and if we can collaborate together, it would be a huge number of availability of ideas and data together. So, but the only problem is how and who is going to be doing it, and how many people are open to the idea of collecting it.
I think times have changed, Emily, and I think practically everybody here would be ready to collaborate.
I think
I'm
if
very
we,
hopeful. I'm a positive person, and I'm hopeful about that.
I think if we make a Google sheet probably and then circulate it around, people will put in their data there.
Yeah, I think we should definitely try to work on it. There could be a large series with so much of data, and it would definitely help not only us as a country, but probably the entire world on that matter.
True.
And coming with places where things are more resource limited, what people think that we don't do the best of stuff, it should definitely be an eye-opener considering how we have actually managed COVID in a country with that number. So if we are able to compile things together and come out with stuff, it will be something which will be really great.
So we can use either PCSI or IAP platform because they all have good place in server. We have to make a kind of registry. So
Mhm.
probably one of us or all of us can finalize a registry and we can start on that.
There is another question from Dr. Arun Wadhwa. Should one expect a flood of MISC in May 2021? Yes.
Yes.
That's exactly what's happening in Mumbai right now.
Mhm.
And there is a very high mortality in children with COVID-19. Um, I think I heard that Dr. Sonu Dani in a group meeting was suggesting that the involvement is not just respiratory, though the numbers are huge and they are overwhelmed right now. But I think all intensivists here and all of those associated with an ICU will see their ICUs full of COVID patients in the next 1 month. That's going to happen. And practitioners would be picking up these patients much more in the coming weeks. That's going to happen. That's a very good question. And I think a kind of an alert for us to tell the hospitals to please increase the COVID beds for pediatric patients. I noticed Dr. Namit is here, and I would be wanting to hear his experience and anyone from Rainbow Hospital, PICU, on and any other ICU of their experience with the shock syndrome. I have not checked everyone who's online right now, but any of the other pediatric ICUs or pediatric intensivists in any city who are here and have experience with the presentation of shock syndrome or other kinds of acute presentations with Kawasaki, with COVID. Namit, can you hear us?
Hello.
Yeah, thank you.
Yes, Dr. Vikas. I was listening to your presentation. It's very good as always. We have had quite a few MISC patients as well. I have lost count, but I would say they're close to around 30 so far that we have treated. We probably tend to see the worst of the spectrum. So almost all of our MISCs have come with significant cardiac involvement. And when I say cardiac involvement, not necessarily coronary involvement, but yes, cardiac involvement. And we have used a lot of steroids and IVIG. The only thing which we have seen in terms of following these patients up is that the cardiac involvement and even the coronary involvement tends to get better sooner than the classical Kawasaki. And that has been the experience in even the published literature from elsewhere. But yes, that has been our experience.
Wonderful, enlightening.
Okay.
Dr. Poonam and Dr. Smita.
Hello.
2 gram per kg. Yes, I think it's. Dr. Sankalp wants to know if the dose of IVIG is the same as Kawasaki.
Yes, it is.
So there is not much difference between the management part in the Kawasaki disease and the MIS. Probably early introduction of steroid is one of the things which is actually a routine thing for the Kawasaki disease shock syndrome.
Yeah, Dr. Shravan Mehra has also asked the same question. Kawasaki and MISC are technically a spectrum of the same autoimmune disease phenomena. Yeah, it's a hyperimmune response, I would say, rather than an autoimmune response. It's a response to a viral infection, a cascade of cytokines released, and technically they would be the same thing happening, except that we see a Kawasaki shock syndrome also, and a large chunk just presenting with prolonged fever without any other involvement, and may have a rare coronary involvement also. So this is the long and short of the what is common between Kawasaki and MISC.
So we can say, like in Kawasaki disease, the actually culprit is not known, and in MISC we think that COVID, this virus is there as a culprit. But there are many people who thought that these are the same thing happening, because initially also Kawasaki disease has been associated with various kind of viral infection, influenza virus infection. And there are many evidence, but genetic predisposition, which is very, very important for Kawasaki disease, has not been seen with the MISC. So the spectrum remains different. So that's why these two cannot converge on a same kind of autoimmune response.
So interestingly, the study from Boston and Pennsylvania, the Children's Hospital Pennsylvania, both said that there is a genetic predisposition amongst the Black population, Afro-American population, and the Hispanic population, as compared to the Caucasian population in their country. But your point is right that, traditionally it's the Far Eastern population which is significantly more predisposed. That is the Japanese population, which is more predisposed, which we haven't seen with Kawasaki.
So the population is different, genetic predisposition remains. Yeah.
Do we give aspirin? Yes, somebody's correcting me between Philadelphia, Sankalp, between Philadelphia and Pennsylvania. I'm so sorry about that. Okay. Do you give aspirin also? Yes, if there is a large aneurysm, I would give aspirin. I think Emmeline wants to say something.
So as far as I was just talking about that, and I thought I would talk about it tomorrow as well. Then since we're discussing it, we can just talk about how the ethnicity has played a different role and what we've observed. There's still, I think we need more data. We don't have enough, but how things have been in the different reports that have been published as of yet. In the US, they've seen a higher predilection for the Asians being more protective in terms of how MISC has presented in comparison to the Hispanics and the Black African Americans. While there's not robust data from UK yet, they're still working on their trials, but from the few case reports that we know of, they have seen higher numbers in the Asian community, more in the Indian and the Pakistanis, who have presented with more shock syndrome. So I think we're still learning in terms of that.
Right.
Sir, I have a question. Hi, sir. I'm working with Max Gurgaon, and with the last wave of COVID, we saw MISC in mostly in adolescents and 2 infants, but the interim age group was spared. Is there something unique to the child between 2 and 10 or something that we are probably missing immunologically? And secondly, what about treatment of mild MISC with steroids on OPD basis? Do you think we would be looking at it as after this wave? I mean, would that be a possibility of treating more of them on OPD basis?
So I would direct the second question to tomorrow when your talk on MISC is with Dr. Emmeline. And regarding the age group, I think the more data we look at, the more clear it will be that it's spread out through the several ages, but it is definitely more severe in the younger population.
Younger would mean?
Younger than the usual. So under 2 years, it gets to be more severe in its presentations. But the coronary involvement by quantitative numbers happens more so in the older population.
Actually, we've seen the opposite. We had coronary involvement in the infants, and we saw shock in the adolescents.
So when we compare, we also compare to de novo Kawasaki, not necessarily within the group of COVIDs.
Okay.
If you get my point. My comparison
yes.
is with de novo Kawasaki, which is what the articles have done, a beautiful comparison between 2005 to 2019. They've taken all their Kawasaki patients and compared them to the current Kawasaki, and they have delineated the differences. And again, I did not go into that because it's a vast area of discussion, and I wanted to focus only on the cardiac elements of it.
Yeah. Thank you.
Sure, pleasure.
Any more questions? I think. Dr. Smita, anything from you, ma'am?
No, it was a real learning experience for me and lot of data Dr. Vikas given us, and really sitting alone, you don't go by those kind of data. Wonderful and wonderful idea that we should create a registry for it, and I will be looking forward to it. I think Dr. Poonam, you can also take initiative for
Yeah,
this.
I think me and Dr. We'll discuss it out, me and Sankalp, and see if we can do something about it.
So thank you very much, Dr. Vikas, Dr. Poonam, Dr. Sankalp, and Dr. Wadhwa, and everybody, Dr. Khandelwal, who has taken a lot of interest in this discussion, Dr. Namit, Dr. Neeraj Avasthi, Dr. Emily, and Dr. Wadhwa, if I didn't take name before. So it was wonderful to be here, and I'm looking forward to next part of this discussion, which we are going to get.
Tomorrow. Okay, so thank you, Dr. Vikas. As usual, very lucid presentation, very comprehensive. And it was a great learning experience. So we know that now in this raging epidemic, cardiac aspect has to be looked in all the time, not just cursory, but all the time. And I really thank you for an excellent presentation. Thank you, Dr. Smita, for chairing the session and for coming in spite of so many problems at home. Thank you so much and sharing all your experience with us. Thank you, Dr. Savita, for the logistical support. Thank you all participants for joining in an excellent question answer session. And tomorrow we look forward to Dr. Emelina with MISC and long COVID. Do join in again, everybody, in large numbers. Today we had 55 participants. Dr. Kohli, you should be happy. So we now look forward to a similar participation tomorrow, and do join in, everybody. Good night. Enjoy dinner and stay safe. Please stay safe, everybody. Stay safe. Bye-bye. Good night. Good night.
Good night.